Hello. Thank you for joining me this afternoon. I'm going to give everyone just a couple of minutes to get settled in. Again, thank you for joining. Hey, Michelle, thank you so much for joining. We're going to get started in just 1 second, okay? Hello, Denise. Thank you for joining. Thank you guys so much. I'm going to give other folks just a minute or so to join us, okay? I appreciate y'all being here. Today we're going to talk about birth control methods. This is a topic that some of my attendees have requested. So as I'm talking, if you have any questions, please feel free to type them in the chat box. And when I get to the end, or even as I'm talking, I'm happy to respond to any questions. So again, thank you for joining. Hello, Arnett. Thank you for joining. Thank you guys so far. We have a couple of people who have joined, a few people who have joined. So I'm going to get started in just a few seconds. Thank you again. I appreciate y'all being here. Can you guys hear me okay? All right. Okay. So thank you for joining. This is Sunday Chat with Dr. Madeline. My goal is to be here every Sunday talking with you guys at about 4 p.m. unless I'm called into the hospital and something else is going on. But I'm excited that you guys are here today. So I am Dr. Madeline, your board certified OBGYN, published author, and international speaker. I'm also the CEO of Control Concierge, and my mission really is to help women, all women, women of all ages, have more freedom and control through either their understanding and use of birth control and contraception, and really more broadly, all GYN care. So again, thank you for being here today. Today we're going to talk about birth control pills. Last week when we met, I spent the time talking about intrauterine devices, or IUDs. Those are increasingly popular among women of reproductive age who are thinking about birth control options. And so last week, some people asked about birth control pills, so I figured we would talk about that today. Hello, Dr. Banga. Thank you for joining. I appreciate all of you guys being here. So let's go ahead and get started. So the birth control pill, many of you guys are probably aware of, but I wanted to, before we get into some of the nitty-gritty about what the birth control pill is and how we should take it and what it does, I wanted to start with a little bit of history about the birth control pill. So the birth control pill became available in this country around the late 1950s. 1960 was about when it was approved by the FDA. And it had an interesting and somewhat unseemly beginning, because the studies that they first did when they were trying to figure out if this method could work for women, it didn't have the most ethical practices, I'll put it like that. So while there were some studies that had included some women in the continental U.S., women in Boston and other parts of the country, what the pill is really known for in the beginning stages are the studies that were done in a less than ethical manner in Puerto Rico. And so one of the things that was happening is that women were excited to hear about this pill that was originally marketed to help women who had irregular menses. But they were excited to learn that the pill also helped prevent ovulation. And so when that became more widely known among women, you can imagine if we were at a place where women had no birth control options, to hear about something that was potentially going to help decrease ovulation and help with birth control was made a lot of people excited. And so There were some studies done as the scientists who developed it tried to get enough information to send to the Food and Drug Administration, or the FDA, which is responsible, the federal agency responsible for reviewing and approving medications in this country as safe for general use. And so, so that's the origin of the pill in this country. So by about 1960, it was FDA approved. And again, some of those studies that were done in Puerto Rico, again, the ethics were questioned because people didn't understand the side effects of birth control pills at that time. And so birth control pills, when they first started in the 1960s, had huge doses of hormones, very much more than what we see in birth control pills today. And those hormones, those high levels of estrogen, basically increased one's ability to form blood clots in the body. And those blood clots would cause women to have strokes, to have cardiac arrest, and there were certainly many untimely deaths with the very first formulations of the birth control pill. And so that's why those studies are always called into question. The studies that involved women in Puerto Rico are called into question. And it's important that we remember some of the starts of these medications and how they may have misused black and brown women when they were first being formulated. So fast forward to today, there are many pills on the market, and all of them have much lower doses of hormones compared to the dose that was in that first type of birth control pill that was used in those studies. And so I'm going to throw out a number there because I think it's important for people to realize how big of a market this is in terms of birth control pills. So we know from some CDC data that as of about 2017, about 72.2 million women in this country ages 15 to 49 were using or had used some type of birth control during that 2 to 3 year window before 2018. That's a lot of people, y'all. And when they look at the breakdown of which types were being used more frequently, the most commonly used type of birth control among those 72 million women was tubal ligation. So remember, we're talking about through age 49. The second most commonly used type was the birth control pill. So 12.6% of those 72.2 million women used the birth control pill when you look at data that was accumulated through about 2018. So that's a lot of people, y'all. Can y'all calculate that? If you can, put it in the chat for me. 12.6% of 72.2 million women in this country. How many women does that equal? Do y'all know? Well, I cheated a little. I checked before we got started, but that's over 9 million women. So at any given time in this country, over 9 million women are using the birth control pill. So it's a really important method to understand, and if it's one that you're interested in, it's an important one to be able to talk with your doctor about, or your nurse practitioner or your physician's assistant, just to make sure you understand the different options that are out there, the different side effects, whether or not a certain type of pill is for you. So I'm glad that you're joining today so we can talk about these different types of birth control pills. So the most important thing to know about birth control pills is that they contain hormones. And these hormones are generally made of either one or two hormones, either estrogen or, I hear you, Arnett. Arnett is saying she went to law school because she can't do math. That's fine, that's fine. We calculated it, and I really just want y'all to know that there are a lot of women, almost over 9 million women who use the birth control pill at any time in this country. So these hormones that are in the birth control pill, they can be either a combination of estrogen and progestin, or just progestin alone. Most women are using a combination type of birth control pill, and so we'll talk about what that means a little bit later. But it's important to know how those hormones work, because sometimes there are some myths about birth control pills. Sometimes people think that they are working in a way that may not align with their ethics in terms of how they want a birth control option to work for them. And so it's important to know that the hormones that are in the birth control, they prevent pregnancy in two ways. One, they prevent your ovary from releasing a egg, so they decrease your ovulation. And if you're not ovulating, then an egg cannot be released from your ovary, and then that means the sperm that might get into your vaginal, through your cervix, up into your womb when you're having sex, that sperm is not going to find an egg to meet with and fertilize to form a pregnancy. So that's one way it helps prevent pregnancy, by preventing ovulation. The other way it helps to prevent pregnancy, and this is more so due to the progesterone component in the birth control pill, is that it helps by thickening the cervical mucus. So I don't have a model here, but basically the cervix is the mouth of your womb. So when a woman is pregnant, the baby develops in the womb. And when a woman is in labor, we check the cervix a lot to see if that cervix is dilating enough to let the baby's head through and all of that. So that cervix, the mouth of the womb, is normally closed tight. And what the birth control pill does is thicken the mucus that's in that cervix, the mouth of the womb, so that the sperm is less likely to get through that mucus, through into the womb, and then meet the egg and the fallopian tube. So that's how the birth control pills work. There are many situations in which we use birth control pills outside of pregnancy prevention. For example, probably the most common use in young women, we sometimes have young women who come in to our office, and if they're concerned about irregular menses or something like that, usually the first thing we might prescribe would be a birth control pill. Now, and I say younger women because when a teenager first has her cycle, and the average age of your first cycle in this country is about age 11. So when she first has her cycle, it takes about maybe 2, sometimes 3 years for that cycle to normalize. And so in that patient, a young teenager, we usually just tend to reassure. We don't necessarily put her on a birth control pill unless she has other things going on, and a birth control pill would help regulate her cycle in a way that she and sometimes her guardian feel would be appropriate for other things that might be going on in her world, whether it's maybe she's actively playing sports, or maybe she has really heavy cycles, or maybe she has a lot of cramps, and so sometimes the birth control pill can help in that way. So I wrote down some other things here because I wanted to make sure we covered everything. So, another question that I get from patients is, how effective is the birth control pill? Is it something that I can really rely on 100% if I really don't want to get pregnant right now? So the birth control pill, when it's used perfectly, is 99% effective. So I said perfectly because that's when we have like perfect scenarios and everyone is able to take everything on time, and maybe they're in a scientific study and they were getting reimbursed to do everything perfectly. So 99% effective. What that means, just to translate, is that for every 100 women who are using the birth control pill perfectly, 1 out of that 100 will get pregnant. Okay? So that's how that translates. Now let's talk about the regular, like, human use. So human, like most of us, like me, when I was in my 20s and 30s, and I was using the birth control pill as my method, there would be many days when, I remember sometimes my co-residents would laugh at me because we might be doing rounds on a young lady who we were going to discharge, and maybe one of the things we were recommending for her was the birth control pill for whatever medical situation she had going on. And there were many times when, in the middle of that conversation of explaining to the woman the birth control pill and how it works, I would literally go, because I try to remember if I had taken mine for that day. And so many of us are human like that, right? We try to remember to do these things at the same time every day, but we have life that happens. And life might mean, for me it meant at that time in my 20s and 30s, really a hectic schedule that was trying to remember and balance a lot of different things at once. For many of the patients that I take care of, it might mean that, maybe they have other children and they're focusing on those children's needs first, or they have family members in the home that they're caring for, or maybe they have a job that is really intense and they spend so many hours devoted to working on things for that job that it slips their mind that they have a birth control pill that needed to be taken preferably at the same time every day. So that's what I mean when I say human. Most of us are human, and when we're human, the effectiveness of the pill goes down to about 91%. So that means of 100 of us who are doing the best we can, trying to make it through days with all this other stuff going on, of 100 of us, 9 of us will get pregnant just because we're human and we're trying to do the best that we can. So what about other things that might decrease the effectiveness of the pill? And so yes, the pill is most effective when we take it on time as we're supposed to every day. But there can be other things that can have an impact on how effective that pill is. So if you have, if you're taking other medications, it's important to talk with your provider, your clinician about these things so that you guys can make a plan and determine whether or not the pill is the best for you. If you're taking other medications, sometimes those medications can interfere with how effective your pill is. If you have other medical things going on, there are times when we don't recommend the pill for you. If you have elevated blood pressure, if you have diabetes that's not in control, if you have a history of having certain types of migraine headaches with aura are when you have headaches and you see different spots or lights that flash in front of your eyes. There's a higher risk for that type of patient. There's a higher risk of them having a blood clot or a stroke if they were to take the pill. And so with that patient, we usually don't recommend the pill. Now there's, I mentioned in the beginning that there's 2 types of pills, one with 2 hormones and one with 1. The pill that has 1 hormone we can often use or sometimes use in a woman who might have high blood pressure if she has, nothing else going on, if the blood pressure is well controlled. For the most part though, if I have a woman with really, really high blood pressure, if she's on like 2 or 3 meds, my thing is, why risk it? We have some birth control options that have no hormones at all, which I think are safest when a woman has other things going on. So I want to talk some about how these are used. I promised I wouldn't take too much of your time, and we're coming up on the end, but I wanted to talk how these are used because I often have patients just call or send emails asking for reminders about how to do this appropriately. And so I'm showing you here just an example of one type of pill pack. And so pill packs basically, they have different things, different aesthetics that make them look different, different companies, different brands. But for the most part, they come in this, this package that shows something happening for every week. So 7 pills for every week. And so they set it up like this to try to provide an easy way for a woman who's taking them to remember to take them the same, to remind her which day she's on. Just an easy way for her to kind of pop the pill out of the pack and go forward like that. And so the way you start these, it's important. So if you are seeing your provider, or let's say you're starting your pills for the first time, you don't have to necessarily have a physical exam, but you have to have a blood pressure check that shows that your blood pressure is within normal limits. If you're starting and you're on the day of your cycle, the first day of your cycle, or within 5 days of your cycle, you can start the pill pack right there, and taking the pill would be effective right away in preventing pregnancy. Okay, that's important to know. If your period has already finished for that month and you're starting a new pill pack, you pretty much want to use a backup method for the first 7 days, and after about 5 to 7 days that you should be safe, in a safe window in terms of pregnancy prevention. That's for the combination pill. Now if you're starting the mini pill, and the mini pill is very popular, I would say for my ladies who have just delivered a baby and they're breastfeeding, they like the mini pill because based on some studies and research that we've seen over the years, the mini pill does not negatively impact their breast milk supply. So if they're breastfeeding and they want to make sure that they have the maximum volume possible, they like the mini pill a lot. Now some more recent studies have shown that if a woman delivers a baby and she is about 3 weeks postpartum, then even taking the combination pill is safe and won't necessarily decrease her breast milk supply. So that's just something to keep in mind for women who might be considering their options. So, what happens now with the mini pill is especially important. The mini pill, now I spoke about the combination pill, how it can be 99% effective. The mini pill, too, can be 99% effective if used perfectly. The combination pill effectiveness goes down to about 91% for us regular humans. And for regular humans doing the progestin only pill, the effectiveness can go as low as 87%. So with the progestin only pill, the recommendation is always, especially for women who are breastfeeding, sometimes women who are breastfeeding believe that they have complete protection if they're breastfeeding and they're taking the mini pill. But when a woman starts to wean from breastfeeding, let's say, she gets to whatever, 4 months, 4 weeks, and she's about to stop breastfeeding, that mini pill is not going to be as effective as if she was doing 100% breastfeeding on demand. The baby is not really getting any other meals except for the breastfeeding. When that happens, the effectiveness of that mini pill is definitely decreased, because once a woman decreases her breastfeeding, and especially if she sees a cycle, that means that the breastfeeding component of that part that's helping protect her against pregnancy, that is no longer in effect once she sees her cycle. That means that the hormone levels have pretty much returned to their pre-pregnancy state. And so those are the main things I wanted to touch on. I know we're just at about 20 minutes now. So I wanted to touch on those things about the birth control pill, and especially to encourage you that if you're interested in the birth control pill, again, it's such a commonly used method. Sometimes I have patients who might try one method, have side effects that might include some irregular spotting, some intermittent headaches, some nausea. I always talk with them about different birth control pills we can try. They can come off one method, one type, and try a different type if they truly know that it's the birth control pill they want to use. And a lot of times people who switch the type of birth control pill that they're using will find that they have greater success on a different type of pill. Sometimes it's just a combination of hormones. There are different types of progestins that are part of birth control pills, and again, the estrogen levels are much lower than what they were in the 1960s, but even within that lower window of estrogen level in birth control pills, there are ranges within there. You can have like from 20 micrograms to 35 micrograms. So, it's important to communicate with your provider. I always encourage my ladies, reach out if you have any questions, if you're having any side effects, to really try to hone in on what might work better for you. Okay? Very important. And for, moms, mother figures, dad figures, significant others who might be listening to this this Facebook Live either now or in the future, again, encourage your partners, if she's on the pill or if she's on anything, to really reach out to her provider, ask questions, make sure she gets the answers that she's looking for, and also to make sure that she's on something that's safe for her, whatever her medical scenario is. And so with that, I want to thank all of you for joining today. If you have any questions, please put it in the chat. Again, thank you. Those, I hope I've responded to each of you. Oh, hello. I'm sorry, I didn't scroll down. Hello, Jean Victor. Thank you for joining. I appreciate you joining today. I have a question here from Michelle. She said, so is the birth control pill the most effective out of the other methods? Great question, Michelle. Actually, the birth control pill can be very effective when it's used perfectly, but we have some long-acting reversible methods that are even more effective. So last week I spent some time speaking about the intrauterine device, or the IUD. That is very effective and works very, very well, 99.9% effective for women when it's used correctly. One thing that happens is that when you remove our human factor, our imperfect human factor of having to remember to take something the same time every day, we have methods that are definitely more effective, like the IUD, or like Nexplanon, which is implanted in the arm. So great question. But yes, the birth control pill can be very effective. Arnett asks a question: if you take it every day but not at the same time, does that reduce the effectiveness, or just if you miss a day? Very good question. So that response differs if it's the mini pill with just one hormone versus the pill that has two hormones. So if it's the pill with one hormone, if you're 3 hours or more late from taking it, you actually have to use a backup method for the rest of that pack and then start fresh. So that definitely absolutely reduces the effectiveness if you're 3 hours late with the mini pill or the pill that just has progestin. If you're taking the combination pill with both hormones, and as long as you take it within the same day, you're generally protected. You're generally safe. If you miss a day, you're usually okay. When you get to missing the second or third day, like I used to do in my 20s, then you have to use a backup method. Yes, absolutely. Thank you for that question, Arnett. Hey, Pam, thank you so much for joining. Appreciate you. And we have another question here from Michelle. It says, if you're menopausal and previously got the depot, would birth control be effective if you decide to use birth control? Great question, Michelle. So if you're truly menopausal, and the definition of menopause is 12 months, at least 12 months without a menstrual cycle makes you menopausal. And so if you've gone through a full 12 months without a menstrual cycle, you actually shouldn't have any more eggs and you shouldn't have any reason to need birth control. But that 12 months is crucial. I'll sometimes have patients come in, maybe they made it to month 8 and then their cycle came again. For that patient, yes, it would be appropriate if they're still concerned about making sure they have adequate protection. It would be appropriate for them to use whatever is appropriate based on their medical situation. That could be the depot like you described, although they have to be careful about their bone density measurement, and that's something that they would usually consult with their provider on. Or I have some women who are perimenopausal who we're not quite sure, maybe their hormones are not yet in menopausal range, and they sometimes just want to use the birth control pill because it just gives them month-to-month control and freedom. Okay. I have another question here from Pam, and she says, what are your views on lower dose birth control pills? Pam, they actually work very well. Really, it's taking it patient by patient. So if I have a patient who is on a lower dose birth control pill, we know they're just as effective, over 99% effective. But if that patient is having side effects, like sometimes when I have a patient who has breakthrough bleeding, sometimes I might have to switch the birth control pill type that she's on, maybe a slightly higher dose of estrogen, just to try to manage that breakthrough bleeding. And sometimes that's all a patient needs to feel that a birth control pill type is working better for her. And I have another question here. Do I recommend birth control or the insertion? Oh, okay. And that question is from Cheyenne. So again, thank you for all these questions. So it depends. Both can be effective. Now, when I'm talking with a patient about what method might work best for her, I like to find out what else is going on in her world. So, you know, if she's very sexually active, if she's really busy, she has a lot on her plate, and remembering to take something the same time every day is a challenge, then sometimes those patients prefer something like the insertion. I'm not sure. So there are two types of birth control that can be inserted. There's a birth control method that can go under your upper arm, which is the Nexplanon. That can be inserted, and that can last for several years, 3 to 4 years. And then there's also one that can be inserted into your uterus, or the IUD. And there are IUDs that can last anywhere from 3 years to up to 12 years. So it really just depends on what type of method and control that woman is looking for. You know, again, the less you have to think about taking something every day, I think the more effective something might be. Again, just because we're all human. I've shared with you my story about how human I was in my 20s and 30s, and how I would often forget. After I had my third son, I had an IUD inserted, and it was effective for 12 years. And you know, there were no mistakes because I didn't have to think about it every day. Okay. I have another question here. What is a day in your life like? Okay, from my wonderful little cousin Cheyenne. So my life is, as a physician, it's different every day. I feel very fortunate to have this thing that I love to do still after all these years that really is very different every day. And so, whether I'm talking with a patient about birth control or whether she's pregnant and we're talking about something during her antenatal visit, or or if I'm talking with a patient who's not pregnant at all, maybe she's menopausal and she's past the window of being interested in birth control pills or anything pregnancy related, and maybe she's just more concerned about sexual libido as she goes through menopause and all of that. I love it every day. My typical day, and now my schedule has kind of shifted. I get more flexibility and control. But there are days when I'm in the office seeing patients between about 8:30 and 5 o'clock. Even during that day when I'm seeing patients, I can be paged to the hospital at any time if I have a patient who comes in labor. Maybe she's contracting, the L&D nurse might call me and say, "Doc, your patient over here, she just arrived. We're getting her admitted and she's 7 centimeters. So then that shifts my day because I'm probably not going to be able to stay and finish seeing all my patients. If my patient who's 7 centimeters gets to 10 centimeters quickly, I have to, excuse myself from seeing the rest of the patients who are there at that time and run over to the hospital and take care of my lady in labor, which we're always happy to do. That's the nature of obstetrics. And if it's a quick delivery, we head back over to the office, finish seeing patients, and then we go from there. There are some days when I'm on call overnight, when I have to prepare things at home for my 3 sons so that they're taken care of. It's gotten a little bit easier as they've gotten older, certainly, but there's always some preparation involved. There are some days when I'm not in the office at all, when I'm in a hospital doing a 24-hour shift, and when I'm doing that, I get whatever comes to me. It might be a pregnant woman. It might be a woman who's not pregnant who's in the ER, but she had a ruptured ovarian cyst, and I have to take her to the operating room. And then there are some days where I spend more time just, reading, doing research, doing what we call continuing medical education. Just there are a range of things that I do, and thankfully, after all these years, I still do them with joy. So thank you for that question, Pam and Cheyenne. So I've gone over my time, but because I promised you guys I would keep it short, I'll go ahead and end here. And if there are other topics that you guys would like to see me talk about in a future Sunday chat with Dr. Madeline, please let me know. Either send me a note in DM or put it in the chat, or reach out to me by text for those of you who are in the live who have my direct cell number. I appreciate y'all being here. So again, my name is Dr. Madeline. I'm a board-certified OBGYN, published author, and international speaker. I am here because I am passionate about taking care of women, and I'm on a mission to ensure that women have the most freedom and control over their bodies by understanding their options as it relates to contraception and also as it relates to overall GYN care. So I thank you very much for joining. And yes, I see. Thank you for joining. I'm sorry. I have another question that I got here, and then we'll wrap up. So thank you, Miss McCain Gatson. Definitely, I'll talk about menopause next week. Okay. That's one thing that several people have asked about, so I will definitely talk about that. And we got a question from Cheryl Denise that says, during this pandemic, how has your practice changed? Great question, Denise. So for many of us healthcare providers, we had to shift things very quickly when COVID-19 hit. So in March, and I happen to practice in Atlanta, Georgia. So in March, we went to a situation where for the most part, we were encouraging people to, stay at home. We were seeing a lot of COVID-19 in the hospitals. And the thought process was that we wanted to protect our patients as much as possible by not having them come in unless it was something truly emergent. There was a rapid learning curve for telemedicine and telehealth for a lot of physicians, nurse practitioners, midwives, physician assistants, to make sure we could still communicate with our patients if something was going on. Now, of course, this does not include patients who may have been in active labor, patients who may have been, 36 weeks pregnancy or later, when it's important that we check their blood pressure and other things. For some patients who had access to a blood pressure cuff at home, it was different. But I would say that was one of the major changes that happened. For women, whether they come in for a visit or if they're in labor, It used to be that many offices in hospital labor and deliveries were very open. One of the things about obstetrics and gynecology is that it's a very family-centered type of practice. And so we went from allowing maybe partners and other children in our waiting areas and sometimes on labor and delivery to just one person. Again, that was to protect the pregnant mom, the newborn baby when they arrived, the OB care team, for a variety of reasons. One, we had a steep learning curve about COVID-19, but also because you guys probably know this already from national media, we didn't have all of the PPE that we needed. So we were really trying to see patients, to keep them as safe as possible, to keep the care team as safe as possible, and so that was definitely a shift. And so now, we all wear masks, even now, this many months into the pandemic. In the office where I see patients, we still just allow one patient up unless she has someone who's vital for her visit, like a translator, if English is not her primary language. And it's important that we have a mutual communication. Then sometimes her translator, someone who might be helping her with translation, is allowed upstairs. The same in labor and delivery. It's down to one person. The other big change that's happened over the last couple of months, as we began to have more data available about COVID-19 and women who may have had no symptoms, there was a study first done at Columbia in New York that showed that as many as 15% of pregnant women who came in labor were positive for COVID-19, and that was among those who had no symptoms. So when we saw that percentage of 15%, more hospitals around the country started doing a routine COVID-19 swab for any woman that came in labor, or any woman who had a scheduled C-section. And so that's another change. But yes, we're continuing to learn about COVID-19 and do a lot of things. And so, together we'll all get through this. And I think we've certainly learned a lot since it started. But there are some protective measures and preventive measures that we have in place still, because again, we're still learning, but also because we're trying to keep everyone safe. So, okay, thank you, Michelle. Okay, so that's another vote for menopause. We'll talk about menopause tomorrow. Thank you, Pam. Very informative. Thank you so much. Linda Pace, great presentation. Thank you so much for joining, Linda. I appreciate it. Arnett, thank you so much for joining. I appreciate you. And Number Lee Thompson, thank you so much for joining. I appreciate you very much. And again, I thank you guys so much for joining. I look forward to seeing you guys on future Sunday afternoon sessions with Dr. Madeline. Okay? Again, I am your board certified OBGYN, published author, and international speaker. Looking forward to sharing with you the passion that I feel about helping make sure women are getting what they need in terms of freedom and control by helping make sure you're aware of birth control options and generally all of your GYN care needs. Thank you so much. Have a good afternoon. Bye-bye. Thank you, sir.
I asked you to do it, I didn't see it.
Oh, yeah, I'm sorry.
I